We're now going to switch to our social scientists. Our first is Dr. Mara Buchbinder, Associate Professor of Social Medicine at UNC Chapel Hill.
Good afternoon. Thanks to the organizing committee for inviting me. I'm really delighted to be here. So I'm a medical anthropologist, and I'm going to speak to you today about ethnographic research that I have undertaken on the implementation of Vermont's law. So the Patient Choice and Control at End of Life Act, or Act 39 as it's known in the state, was passed in 2013. The legal requirements are largely identical to those in place elsewhere, so I won't go through them. And as of this past June, paperwork for the law was filed with the State Department of Health for 52 patients. So my study uses qualitative and ethnographic data, so naturalistic observations, that I collected between 2015 and 2017 to address three primary questions. How do ordinary people understand, access, and contest aid in dying once it is legally authorized? How do healthcare providers and policy stakeholders accommodate or resist aid in dying as a new end-of-life practice? And finally, what are the ethical challenges for clinical communication in the patient-clinician relationship? I conducted 144 semi-structured interviews lasting about an hour on average, and this included interviews with 29 physicians and 29 nurses, chaplains, and social workers from oncology, neurology, palliative care, and family medicine or internal medicine. 18 of these were physicians who had direct experience with Act 39, either as prescribers or as secondary physicians. And because Vermont is small, this means that I was able to talk to a majority of the prescribers in the state. This map shows basically that my interviews took place all over the state, with the larger circles representing a higher number of interviews, particularly around the metropolitan regions of Burlington, Montpelier, and Brattleboro. So with my limited time, I want to make two key points that are emerging from my research, and analysis is still ongoing for this project. First, the challenges for physicians are much broader than grappling with whether or not to write a prescription, and I'll tell you a little bit more about what some of those challenges are. And second, the communication challenges are broader than just figuring out how to respond to a patient's request. So I want to here push back ever so slightly against the title of this panel, which refers to responding to patient requests. So let me briefly take you through each of these points. So much of the literature has focused on physicians' willingness to prescribe under assisted dying laws, and the physician's role is actually much broader than this. It includes determining if patients are eligible and meet prognostic and competency requirements, as we've heard a lot about today. Some physicians in my study expressed concerns for the fact that a patient could be competent at the time of prescription, but not when the medication was actually ingested, and that there aren't any legal mechanisms in place to ensure that patients remain clinically eligible. In Vermont, and this is also a little bit unique, it's left entirely to physicians' discretion to determine who counts as a state resident. There is no 6-month requirement as there is in Oregon. So Vermont has had cases of patients moving to the state in order to access the law and even moving into long-term hotels. And this is something that some physicians struggled with, that it was up to them to decide if someone would count as a resident. Nurses and social workers, as well as physicians, helped with all aspects of the bureaucratic process, including finding a second physician to certify eligibility, identifying a pharmacy, and completing the paperwork. And many providers felt really isolated in navigating this process, particularly those in private practices and in more rural areas. There was a sense that many providers were sort of reinventing the wheel each time they started the process because there were no protocols to follow, and many couldn't turn to experienced colleagues for guidance. Some were able to connect with advocacy organizations for support, but not all did so. Surprise that Act 39 did not actually stipulate what to prescribe for patients was a common sentiment. Physicians did note the usefulness of Compassion and Choice's doc-to-doc program, which enabled them to speak with experienced physicians in other states. And finally, some but not all physicians were very involved in planning for the death itself, such as making contingency plans for possible adverse events. Some doctors and nurses were present at the patient's request for the death itself in order to help deal with emergent adverse events or otherwise provide social support. And I think it's worth noting that even some physicians who did not prescribe were involved in other of these steps because they felt really committed to supporting a patient's wishes and to the ethos of non-abandonment. So they might sort of engage in other aspects of the bureaucratic protocol. One of the things that I've been very interested to see is the way that providers conceptualize this work varies considerably. There are some who see it as kind of lying on the spectrum of palliative care and no different from other clinical services that they would otherwise be providing in their normal day-to-day clinical work. And then there were others who saw it as incredibly emotionally and morally burdensome, though they were often still grateful for the opportunity to participate. And one physician in my sample who was a bit of an outlier had been one of the heavier prescribers, ended up deciding to retire early in large part due to the burden of Act 39. Physicians spoke to the learning curve involved with implementing this into clinical practice. I'm not going to read the quotes because of time constraints, but in the first example, the physician reflects on the extra legwork that she and her colleagues did with the first case that came up in her hospital. And then the next quotation is from a physician whose patient died before completing the bureaucratic protocol. And the patient went on to have a really sort of brutal death during the 2-week waiting period. And the physician felt terribly that she hadn't gotten the bureaucratic process going sooner. And these timing issues came up again and again in my interviews by both these concerns were raised both from providers and from family members as well. And I wanted to note as well that there aren't any formal mechanisms in place, at least in Vermont, for sharing some of these lessons learned. So my second key point has to do with thinking about communication about assisted dying as broader than just responding to patients' requests. Many physicians and bioethicists operate with the presumption that communication about assisted dying should be patient-initiated, and we heard that earlier from Dr. Fromme. And that sort of view is reflected in these titles from published guidelines and recommendations in the literature. And obviously, this is a huge issue. Determining how to respond to patient requests for aid in dying in a thoughtful, compassionate, and comprehensive manner is a critical issue facing physicians. But I want to suggest that it's not the only ethical issue for clinical communication. Several years ago, a lawsuit was filed against the Vermont Board of Medical Practice alleging that Act 39 entailed an affirmative duty to inform terminally ill patients that Act 39 was an option in their state, and that the law therefore violated the constitutional rights of these physicians. Now, the lawsuit was ultimately overturned, but it did raise this important ethical question of whether physicians should inform patients about assisted dying laws. And there are strong ethical arguments on both sides. What I want to do now is to briefly show you some data on what physicians and nurses who counsel patients about Act 39 in Vermont are actually doing. So the issue of who should initiate this kind of a discussion came up in 19 interviews with physicians and nurses who had experience counseling patients about Act 39. And 8 of these providers reported a practice very similar to what we tend to see in the literature. They wait for a patient to initiate a discussion of aid in dying. And this is a typical response in which the physician said, I think because it's new and people are sensitive, people pretty much across the board feel that it needs to be a patient-directed question. Okay, this is a view from a specialty clinic nurse practitioner who raised concerns about the potential that raising the possibility of hastening death might damage the patient-provider relationship. So she told me, if I bring that up and it's something that they wouldn't even consider, that could create a huge scar in that relationship. Unless that door was open, I would not bring it up to a patient. On the other hand, 11 out of 19 clinicians indicated that there are circumstances in which they might themselves initiate this sort of a discussion in the absence of a patient's request. And here are a few examples of this view. They're all from physicians. I try to bring it up as it's part of the slate of options, but I don't dwell on it, and a patient will pick up on it if it's something they really want. I think I want my patients to understand everything that's available, and I don't think it's fair to leave a patient in the dark. Whether or not they want to do it or ethically agree with it is not the issue. And finally, I think I brought it up maybe twice with patients, but it would take very unusual situations. So what this says to me is that we all really need to be thinking about the circumstances in which it might be ethically permissible for physicians and nurses to inform qualifying patients about aid in dying. And I don't want to minimize the fact that there are real ethical questions at stake here that are not easily resolved about the nature of professional responsibility, potential harms to the doctor-patient relationship, and the potential for undue influence. But I think it's worth acknowledging that providers are actually bringing it up, and I think we need to grapple with that. So I'm running out of time, but before closing, I wanted to mention one reason why I think it's worth reconsidering the conventional view that communication should always be patient-initiated. And this is because patients who already know about aid in dying are likely to be more educated. And this is sort of what a physician in an earlier quote that I shared said when she talks about the population that's going to ask about this, they're a savvy population. So waiting for patients to initiate a request might create access gaps for patients from less advantaged populations. And this is complicated because for some, this might seem like good news because of concerns about vulnerable groups being coerced into using this. But I think we also need to sort of consider the flip side, which is the fact that public policies that privilege access for relatively advantaged populations raise justice concerns, and that data showing lower utilization of aid in dying among low SES groups might reflect unequal access rather than a weaker preference for aid in dying among these groups. And these are issues that I've written about elsewhere, so I've included some citations at the end. So I'll stop here, but I just wanted to briefly acknowledge support from my funders, the Greenwall Foundation and the National Science Foundation. Thank you.